So this meeting is being recorded, and we're so glad to have you. Thank you so much, Hasita, and thank you to the Nursing Public Health Network for your commitment to racial equity and issues of social justice. It is because of your thought, partnership, and leadership that we are all here tonight. So as was shared, my name is Kiala Jacques. I am one of the assistant directors at SOURCE, the Community Engagement and Service Learning Center, and it's my privilege to invite you to tonight's conversation. I'm fumbling a little bit with technology so that you can see some of the slides that will tee up our conversation around medical apartheid. I'm very excited. Maybe nobody else gets excited about having conversations about race and racism, but I get very excited because it means by naming these things and talking about them together, we can actually make different choices. And we can engage with choice points by moving beyond our assumptions, our biases, our fears. So we have an illustrious panel. I don't want to stand between you and them, but I have to do a little bit of commercial work first. So I want to start by making some acknowledgements. I want to acknowledge the First Nations people who are the traditional custodians of the lands that we reside on. I want to acknowledge the Piscataway tribe of the Chesapeake Bay region, the elders past, present, and future, for they hold the memories, the traditions, and the culture of the area. I also want to take a moment and acknowledge the impact of racism, systemic oppression, including the practice of redlining, colonialization, genocide, and state-sanctioned violence on the lives of Black and Brown folks. Now, anytime I facilitate a space, if you've ever been with me in a space, you know that I always encourage us to think about the ways that we can be together and to agree on how we will choose to be together in this space. So here are some agreements that we tend to use as standard. And if you could think of some more to add, we invite you to add those to the chat. So the first agreements that I ask you to consider is to smile and to engage. We are going to be talking about and naming some challenging topics, only challenging because as a culture, we are not, as a society, we are not acculturated into naming racism, naming white supremacy, and really acknowledging the impacts that they have had on the lives of BIPOC folks. So we're going to do that today, and it may make us a little bit uncomfortable, and our bodies may start to respond accordingly. But I'm going to ask you to meet your learning edge, to re-engage your body, to use your smile and your deep breathing, to really bring your amygdala back down. It'll be a little hijacked perhaps, and bring it back down so that you move away from fight, flight, or freeze and move towards learning, towards justice, which really is about thinking about relationships between all of us, for all of us. I'm going to ask you to reflect. There will be reflection questions and intentional reflection activities. And so that means sitting with what is and thinking about what could be. I want to invite you into that process. And that means that you may have to connect, not just to yourself, but to others. You may have to meet others where they are. And so I want us to be mindful and intentional about that. And speaking of being mindful and intentional, we're going to be mindful of our words, because if you don't recall kindergarten, first grade, second grade, where that person said that thing about your glasses or your hair or your shoes, I definitely recall it. And those words still have impact today in my adulthood. So we're mindful that words matter, and we're going to use intentional language. So regardless of our desired intent, we're mindful that these words have impact. And so we're going to just mindfully use our words and language to include all of us and build a space for us all. That means we're going to tell our own stories, and we're going to use I statements. This allows us to not make gross generalizations and not to, again, engage in exclusionary language, but we can speak from the expertise that is our lived experience by using I statements. And as we share these stories, we might find that we learn and have these aha moments, and that is spot on. That's exactly why you're here. So we want you to take those learnings with you, but leave the stories here. We can't guarantee confidentiality. We can't even guarantee to make this this space safe, but if we mindfully tell stories from our own perspective and leave the stories that we hear here, we can honor other people's lived experiences and their vulnerability. So that means when we hear something that we may have heard for the first time, may agree with, may not agree with, we can acknowledge that it comes from somebody else's lived experience. And instead of nullifying it by using words like but, we can use words that expand the conversation to include our language by using statements like yes and. So I'm going to invite you to use some more new and developing language. And then the very last thing that I'm going to ask you to consider to agree to is to be very brave about claiming your mental liberation. This actually means taking responsibility for not just learning new things, but doing new things as a result of our learning. That means we'll have to unlearn some things and learn new things. So if you feel like you can agree to this, I just want you to use the chat or use your buttons or use your emoticons and let me know. Give me a hand clap, a thumbs up, a yes, I can, something. Let me know that you can agree to these things. And if you have other things to add, feel free to use the chat. We can definitely update these as we go. There they are. The agreements are coming in. I'm so excited about the space that we're building together. Thank you so much for indulging us in those agreements. So here's our agenda, and I have the pleasure of being your Sherpa, your MC for the first half of tonight, where we will engage in an amazing panel conversation on medical apartheid, health practice, and education. And then we're going to break into our workshop component. So we have like 45 minutes of really rich conversation. You're going to submit your questions to the chat. We're going to pull them out. The panel's going to respond. It'll be phenomenal, but don't leave, because we'll move into intentional reflection time. We'll create some collective strategies for action so that, again, we're not just soaking this up, but we are acting. We're enacting justice. That's what the Practicing Justice series is all about. And then before we go, we'll have some collective conversations about the things that we reflected around, the themes that came out of our reflections, and what we can commit to doing next. And as Asita said, we have lots of amazing raffles and giveaways, so you don't want to leave early. You want to stay to the end, because you never know. You just never know. Stay till the end. With that being said, I am really excited to introduce you to the panel. So I'm going to stop sharing my screen and tell you a little bit about these rock stars. So I'm really excited that we have with us tonight Emeril Jenkins. Emeril is a first master's entry. She was one of the first master's entry in nursing students to continue as a dual D&P and PhD student at the School of Nursing. And Emeril is adapting the Capable program to focus on meeting the needs of older adults with co-occurring Alzheimer's and related dementias with physical disabilities and their caregivers. So the Capable program includes families and the role of their caregivers. I'm also excited to let you know that Emeril is the former American Association of College of Nursing GNSA advocacy leader for Maryland, former president of the Black Student Nurses Association, and created the medical terminology course for the Mayor's Office of Employment Development Job Training for Youth. So we have not just an illustrious scholar, but a rock star practitioner in our midst. Also with us is Graham Mooney. Dr. Graham Mooney is an assistant professor of the history of medicine at Johns Hopkins University School of Medicine. His research focuses on the history of public health interventions and the relationship between public health policies and population health outcomes. Dr. Mooney also has an appointment in the Johns Hopkins Bloomberg School of Public Health's Department of Epidemiology and the History of Science and Technology Department at Johns Hopkins School of Medicine. His research covers the history of public health in Britain, North America, infectious disease surveillance, epidemiology, and demography. And I have the pleasure of knowing Graham and the work that he's done around building anti-oppressive teaching and learning communities. So really excited to have you with us here, Graham. And last but definitely not least is Ruth-Alma Turkson-Ocran. So please redirect me if I got any of that wrong.
It's Turkson-Ocran.
Turkson-Ocran, thank you. With a name like Kiala, you know, you just have to do better in the world. So Ruth-Alma is a PhD, MPH, PRN, FNPBC. The work has been done. I say all that to say the work has been done. And is board certified family nurse practitioner and an American Heart Association strategically focused obesity research network postdoctoral fellow at Johns Hopkins Bloomberg School of Medicine. Prior to receiving a PhD from Hopkins, she received a master's in nursing and a master's in public health and health promotion, behavioral science at the University of Texas Health Science Center at Houston, UT Health. She attended Lincoln University in Jefferson County, and her undergraduate studies were obtained as an associate bachelor's of science in nursing. Her research includes chronic and cardiometabolic disease and the risk factors and complications for immigrant health, the social determinants of health, social justice, and health disparities. She has experience working on the national database and on cohort studies examining cardiovascular disease related outcomes. I could go on and on with these bios, but then we wouldn't have time to hear from these phenomenal individuals. So I'm going to jump right in with these questions. So what brings us here tonight is this conversation around medical apartheid. And the book, as we know it, chronicles the history of medical experimentation, exclusion, and exploitation for non-dominant, non-power holding groups, and in particular, Black people. But let's be very specific. This book opens by naming and chronicling the experiences of Black women. So this is for our full panel, but I definitely believe that Graham has spent a lot of time speaking into this space. Will you talk about how this came to be normative for more recent health professional practices?
Yeah, thank you, Kiala, and thank you for the honor of being part of this discussion as a white cisgendered male in a very resource-rich environment. I'm aware of the privilege from which I speak, and I've learned a lot from both yourself and other people working in this area at Hopkins. So what I'm going to say is part of some work that I've been doing with colleagues in the history of medicine and department at Hopkins and sociology around issues of the history of race and racism in American medicine. I think the thing that, first of all, understanding what structural racism is, that helps explain why medical apartheid is so important in the ways in which history and contemporary racial inequities are perpetuated by the structures that we can observe through social and economic and political systems and where power resides. And so because of those structures, you get variations in access to healthcare and so on. But I think the thing that medical apartheid does, as speaking as a historian, is it doesn't just show that racial ideologies and racism were sort of incidental to the development of American medicine. They were absolutely central to it. We wouldn't have American medicine and healthcare in the shape and form that it is now without those racial ideologies. And we can talk a bit more about those historical examples later on. But it's absolutely essential. And not only was it essential to the creation of modern medicine, but it was also essential to uplift and to uplift and disproportionately advantage those who benefited from it, from structures of racial discrimination. So medical experimentation on Black bodies was crucial to the formulation of medical schools. Talk about that maybe a little bit later. And the development of entire fields of medicine, such as anatomy, obstetrics, and gynecology. And not only did it benefit, predominantly white practitioners, but it also caused it also enacted great violence and damage on the people to whom it was subjected. So I think that that's the work that medical apartheid does for us in understanding that deep history.
Thank you so much. And I'm going to open the floor to our other panelists if they want to respond to that question, but I'll maybe layer onto that because Graham talked a little bit about the intentionality. I'm curious if you all can also speak to why do you think it continues to be unacknowledged in medical practice?
Okay, so first of all, I wanted to talk about how it's become normative. So to understand how something has become normative, I had to look back at the past. right? So imagine institutionalized racism in 1835 in the US, when a Black woman who died over the age of 100 named Joyce Heth was regularly examined by physicians and laypersons, and her autopsy was attended by 1,500 paying spectators. Or let's move to 1850, when a Harvard biology professor, Luis Agassiz, commissioned images of 15 nude and semi-nude African Americans in Columbia, South Carolina, to emphasize head shape, profile, stance, and provide graphic evidence that Blacks were a different species than whites. Okay, moving along, let's skip to Ota Benga in 1910, a Black widower from Zaire who was exhibited in New York's Bronx Zoo. Then Margaret Sanger in 1929, who researched birth rates in Harlem, New York, while planning the Negro Project, an experimental initiative to reduce births among Blacks. Okay, we're going to keep skipping, going to the 1970s, when physicians and researchers supervised experimentation of inmates, most of whom were Black, at the Holmesburg Prison Complex in Philadelphia. Many of the US prison research survivors of that time have since sought legal redress regarding the experimentation that happened in the prison system. Okay, and then in 1996, the secretary, so we're getting closer to today, the Secretary of Energy spoke to journalists about declassifying records of radiation experimentation on unsuspecting American citizens, many of whom were Black. In early 2004, it was identified that Detroit hospitals were infusing polyheme, which is an alternative blood substitute, randomly into severely injured, usually unconscious, ER patients who could not give or withhold consent. So this takes us to today, an answer to your question. How has medical apartheid become normative in most recent health professional practice? I think the National League of Nursing in 2016 said it best. As nurse leaders and role models, we acknowledge that the theory and practice of our profession has evolved within a Eurocentric context of colonialism, and that humility and risk-taking are ethical responsibilities required to face our own biases and limitation in relation to decolonization. So a lot of big words. What does that mean? Medical apartheid is normative because it evolved from colonialism, which just means people occupied a place and made it profitable for themselves, such as was the case in South Africa or in slavery in the US, and that has impacted healthcare worldwide. It caused the transfer of new diseases, which changes population densities, which impacts the economy. And now we're in a cycle of poverty related to illness and illness related to poverty. This is normal. I'm going to give you an example of what's normal to hear today in a lecture. Blacks are more likely to have hypertension, diabetes, hypercholesterolemia, etc., in relationship to lifestyle choices. So in practice, you walk in, you see a Black person sitting in a chair, and you think, what are the top Black diseases I just learned? Rather than, how is this person's lifespan impacted by their zip code, which has predicted health status in a 2016 Viceroy study? Or how is this patient impacted by trauma? There's so much to think about. Okay, so medical apartheid has become normative in recent health professional practice because it evolved from a history of colonialism that we are unpacking daily as a nation.
I absolutely love your response, Emeril. And I guess to follow all that historical context, when hearing the question, I was just thinking, essentially, in addition to what you said, essentially the models of education have also not changed since way back. The same equipment or tools are used, and we can go back to thinking about the speculum, for example. In addition to that, the same and challenge knowledge that was practiced back then has been passed down or inherited because practitioners feel comfortable with, I guess, what is existing or the status quo. we can go on, but for example, you're looking at pictures that are not exactly representative of the community within which, let's say, a practice is or an institution is, using descriptors or using, I guess, whiter skin as the description of what is normal, for example. So I on one hand, I think that's one aspect of it, but also and also, so I'm trying to reframe the development of the mentality of the association of one group of people as being the other normalizes negative behavior, and it takes I feel like it takes empathy out of a negative behavior. So you have that me versus you attitude, for example, and that is another reason why injustices have been carried out, and people think that that is, what they should do, that it's normal, and then begin to lose the, what's the word that I'm looking for? They begin to lose, I guess, the conscience behind that, the conscience of good as bad. And so I feel like, taking time to, like who has really taken time, or have people taken time to look at what is going now and say this needs to be changed, structurally, this needs to be changed in terms of, structural racism, lack of representation, and if it's done in the past and accepted in the past, why did it become normal or tradition, and also the non-involvement of people with different perspectives causes everyone in the same group to think the same. So if, let's say, you're trying to make maybe policies, for example, everyone is thinking is maybe of a similar group, you don't really have representation from different groups, then you're just going to have the viewpoint or the experience of one group, and that's going to be what is essentially I guess, implemented. And so these are just some of the many thoughts that were just, going through my head. Yeah, things just become normal when you think about things this way.
Could I just add as well, how that non-participation, one of the ways in which it became normalized in the American medical profession. So some of you may or may not have heard of the, you can put your hand up and say if you've heard of the Flexner report from the early 20th century. It was produced in 1910, and it was a survey by Abram Flexner, an education specialist, who went round the US and Canada surveying all the 150 or so medical schools with the aim of standardizing medical education. Okay, very kind of normal process for lots of professions in this period. The thing was, what happened is that the rationalization of medical schools occurred. So the report was in 1910. By 1923, the number of medical schools had been slashed in half. Okay. The thing was, there were only 7 medical schools who took African American students. That was reduced to 2. So you have a baked into the emergence of the American model of education. And Johns Hopkins was held up as being the model of 2 years basic science, science research, and then 2 years clinical research. That whole process was founded on the fact that African Americans were not considered worthy of studying medicine. In fact, Flexner said, the black population, black students should study hygiene rather than medicine. And so you get a system whereby African Americans are being excluded from the very training and education that would reproduce African American physicians. So in 1910, about 2.5% of all physicians in the US were black. In 2008, it was 2.2. So yeah, that whole process, that path dependency, as we call it as historians, was set in train by this Flexner report in the early 20th century. I think it's a little bit more today, but it just goes to show that the work that has to be done to get proper representation and participation, as Ruth-Alma was saying, in the present.
So this was rich. Not only did we walk through over 225 years of medical experimentation on Black bodies, we discussed over 100 years of exclusion from medical education and the perpetuation of the status quo of educational standards based on the preferences and beliefs of the white dominant population. And then we talked about how that's been reinforced, not only through the dehumanization of Black people in particular, though they're not the only ones. Definitely this is a BIPOC conversation, but we have explicit documentation about the role in Black lives. The socialization and exclusion and bias exclusions, right, that led to dominant medical beliefs and the lack of acknowledgement. So I think, Graham, your final point was really poignant. Like, I don't know that in anybody's introduction to their health professional education at Hopkins announces that it was a part of exclusionary practices for Black and brown folks, right? And the numbers speak for themselves on how inclusionary they tend to be. And this is not to vilify Hopkins, but to tell the full story of an institution that's been around for 100 years, and we walked through over 225 years of history. They've been around for 100 years, and we're still seeing the numbers and representation of graduates in this field be about the same as they were in 1923. So significant. And it actually perfectly segues into this next question, because I think we answered the question around why it hasn't been addressed, right? It's serving a purpose. So when we think about the role of education here, I'm curious to hear from you all about the role of education in shifting oppressive narratives, norms, practices, policies, and procedures. What has it looked like? What does it look like? What does it need to look like?
I guess I guess I could start. And so I think one is so in an institution, I guess in an educational institution, one of the things is to I guess education. So you can let students also educate themselves, or in addition to, you know, I guess the pedagogy that is, I guess, handed out to them, but they, you know, like students also do that, advocate for others, especially for parity, bringing to light injustices that you know, they see, not being afraid to speak up. So there also should be, I guess, in whatever institution you find yourself, should be, I guess, safe spaces to do that. And with, I guess, with the education of, you know, people, you know, younger people, you have fresh eyes that are looking at what is the status quo. And so I feel like those fresh eyes, those fresh bodies should keep what is supposed to be the status quo accountable, and say, you know, and call it out. And I feel like institutions should allow for that, have procedures and policies for doing that. I think that's what I'll start with that.
Okay, and I was just going to go to an article titled Nursing Colonialism in America, Implications for Nursing Leadership by Waite, Waite, I hope I'm saying that right, and Nardi, 2017. So they literally outline beginning strategies to decolonize education in the nursing profession. So these same strategies can be used by educators to shift oppressive narratives, norms, policies, and procedures. So to give an example, let's say we need to shift an oppressive narrative related to inclusion and exclusion. We can regularly examine the leadership track and knowledge development machine at our place of business and ask, how does it include and accommodate diverse membership? Or let's say we need a shift in oppressive norms of an ethnocentric nursing education curriculum. We can teach students to broaden their perspective, to understand the different worldviews of a diverse nursing workforce and their patients, while also teaching the skills to challenge discriminatory behaviors. That's enough. Okay.
I think Emeril has just really encapsulated the things that I would like to say. But I think education more broadly, taking a structural step back and thinking about the leadership and the structures. I did some work not so long ago on doing some research on the board of trustees in the School of Medicine. How many people in the Hopkins School of Medicine are BIPOC? 2 on the board of trustees of the Johns Hopkins School of Medicine. And so until you change the structure of an educational institution at the top, you're not going to get the cultural change that is required that will then go down. I'm not claiming that trickle down, you have trickle down culture here, but unless the actual composition of the leaders of the educational establishment change and consciously change, you're really not going to get a serious change of attitude. So I think that's really important, is to look at the leadership, look where the leadership for education is coming from, and to challenge that leadership to reflect what is required. So that's another important thing. And I think the other hard thing is, I think it's really difficult in an education setting I co-teach with colleagues, first-year med students in social medicine, and it's really hard to convey that anything can actually be done. On the one hand, we can help students understand, the structures of power differentials. We can help them recognise what they are. You can sit with patients and ask them not just about those lifestyle habits, that they understand their circumstances. And Ruth-Alma, I totally get. I mean, the whole lifestyle thing is a whole different thing, but it's I think it encourages placing blame on the individual. But I think translating that knowledge into actual practice and understanding is really hard. So I think a lot of work has to go into that nexus of, I understand what the structures are. Here's a patient in my clinic, in the home setting, wherever, that I need to care for. How do we make that connection? And I don't know what the answer is, but I think we've got to work on that.
So I heard so many gems. I'm just going to share back what I heard. I heard, if we're thinking about this at a micro, meso, macro level, at a micro level inside of the classroom, we have to be really intentional with teaching students skills for analysis and historical perspectives, and not just teaching them, helping them apply those in practice. So I heard you, Graham, feel as though, communicate as though you're not sure what the road forward is. And I'm going to push back a little bit, because I've seen you at work on teaching faculty anti-oppressive frameworks. It is then teaching students anti-oppressive frameworks for practice. At the meso level, thinking about how are we training faculty to offer those things in the classroom, and how are we thinking about management and practice, ensuring that management has the tools to practice that same level of analysis and the power to do some course correction as they do that level of analysis. And then I heard Graham say, and actually you all said this, at the macro level, at the power holding level for policies, practices, procedures, and hegemonic practice, we need more representation. There has to be diversity there, so that there's not just diversity of thought and perspective, but even thinking about students as uprisers, as they historically have been in social justice movements, holding those leaders accountable, and the leaders having mechanism by which the leaders hear and take into account the things that they bring forward, as they are the closest, not just to practice, but to the literature, because they have to be well read on it as a student. So that was so many gems, so many. You just gave an entire strategy, idea strategy for us to consider right here at Hopkins. I'm mindful that all of you have been working, not just in studying about this space, but in your various practices to really bring shifts and reorientations to education. And so what I'm curious if you could share with us what steps can be taken to shift ideologies, to shift pedagogies, to shift curriculum in health professional schools, and think specifically about those that we have in the room. What call to action do you have for students to be a part of that shift?
Okay, so when thinking about the steps of shifting ideology, I looked at another article. I went to the 2020 Nurse Education Today article titled "Dismantling Racism in Education in 2020 in the Year of the Nurse and the Midwife. It's Time," which I co-authored. Okay, so the article mentions ways in which nursing education can begin to overcome structural, individual, and ideological racism. A successful, decolonized, all-inclusive curriculum should include these 4 changes, which ultimately will shift ideologies. 1, learning resources must reflect multiple ethnicities to account for differences. For example, jaundice, and similarities in assessment and diagnosis. 2, higher degree nursing and midwifery researchers, and I would go so far as to say other healthcare professionals, should not teach students to merely control for race when healthcare disparities, such as health access, are pivotal in the burden of disease. 3, race must be challenged as an unproblematic risk factor for disease in course material. Clear reflection needs to show the impact of structural, individual, and ideological racism and subsequent weathering on health status, okay? And then 4, increase visibility and influence of BAME BIPOC, and we've used that word a lot. So it's Black, Asian, minority, ethnic, Black, Indigenous, people of color, okay? And faculty and academia and leadership to continually counter the effects of colonialism and racism. Okay, so educating a group of healthcare providers whose learning resources reflect the social justice of all marginalized groups amidst COVID-19 would be a true shift in ideology.
Ruth-Alma, do you want to go?
Oh, sorry, I was responding to something in the chat. You could go ahead.
Yeah, just to confirm, BAME is used more commonly, certainly in the UK. And I think I'm just going to sit down after Emeril. That was just fantastic. So I don't have 4 coherent points. One point I do have is, though, it needs to be more than just a diversity tick box as well on behalf of the institution. There needs to be serious money put into this and serious, in effect, reparations for the damage that's been done in terms of access to education and quality of education for BIPOC folks. Because without that, people aren't going to do it. We've found, Kiara and I have been doing some anti-oppression pedagogy work at Hopkins, and it's very difficult just to get people to enroll because their time is tight. Curriculums are packed already, so you have to intentionally create space and funding in the curriculum, and it has to be ongoing. You can't just do an online course, and it has to be ongoing, and there has to be support for. Not everybody knows how to evaluate their own syllabi and curricula to detect why it's colonial and why it's oppressive. So there needs to be ongoing support to enable that stuff to be picked apart, put together again, and then maintained. And I think genuinely, the answer to that is money, but also it has to be invested properly and wisely.
Great. I do totally agree with what Graham said. And in terms of, like us being intentional, going into, let's say, first going in I guess, going into the classrooms or in lecture halls or however we are now, if you're, for example, if you have text or articles for students, for example, you do want to be intentional about selecting them. And I was excited when Graham talked about like the pedagogy. So it took me back to like reading like The Pedagogy of the Oppressed by Paulo Freire. But using like the dialogical approach, so giving students the room to engage and explore what's happening. Just have a good dialogue. Whatever you're teaching should also make sure that while you're teaching, you should make sure that you're highlighting injustices. And making sure that you're going over things that are ugly, scary, sad, neutral, and I think not even starting, I guess maybe going a little further from this, but this is mainly talking about health professional schools, but I think in general, this should also kind of be started early. And this is way before people get into like the health professional schools. So I personally believe, start as early according to whoever's comprehension it is, and seeing who writes these books, who writes the articles, is there representation, who is at the table, what is the framing, is there whitewashing or otherwise of the content that it's presented, or is there like rewriting of history or facts, for example. And going back to, I believe, something that Emeril said, and either she said that, but I did remember reading that in the paper she just said, of course, using race that is perpetrated through medicine. And why is that being done? Because it was collected. And I feel like its prominence has been exaggerated such that when you're examining, let's say, health outcomes, and you're looking at it, maybe even in statistical analyses, for example, you adjust for race, and it's essentially considered a sin if you didn't adjust for race back then. But however, you're looking at something that is a social construct, and we've come to a point where, people are now, questioning its use and risk equations and lab results. Think like looking at the EGFR, for example. So what steps can be taken and to shift the ideology? I don't know, but I think I think we are in a good place where now people are wondering what is the best way to examine maybe the disparities that we're seeing. And I think it goes back to something that Emeril said about trauma. How do you examine trauma? How do you account for trauma? Because I personally think that at the root of all these disparities are trauma in different ways, whether it's emotional or, but the basis of it starts structurally. And I guess with the forced kidnapping for Black people, for the first, the forced kidnapping was the original sin that birthed different babies into, like Jim Crow, redlining, and so on and so forth.
Thank you. So again, Jules, I don't know if anyone else is taking notes, but there are lots of gems dropping, and I'm going to just share a few that I wrote down in my notes, and then I'm going to encourage you who have questions to put them in the chat. So the gems that I heard were intentional engagement with diverse educators. bringing diverse educators into institutions, and intentionally naming not just race, but colonialism, naming weathering, which is the accrued impact over time in the health of Black people and over generations, right? Naming the structural and the socialized components that contribute to different outcomes that we can quantify by race, but we have to acknowledge the role of racism. So valuable. And thinking about access points at institutional levels, how do we intentionally secure funds to ensure that we are providing educational opportunities for those who are the descendants of those who were the experimental chattel, right? And foundations for the practices that we all know. Really valuable to think about that being a call to action. And also incentivizing the development of our faculty. If we are not only including diverse faculty, we need to give the opportunity for current faculty to have professional development and course rehabilitation, and that needs to be incentivized. It needs to be held up and valued just as much as their research and their service. Valuable, so valuable. And then thinking about the role really of shifts, making shifts in the classroom. So thinking about how we can intentionally construct our courses so that we, even as early before you make it to a graduate health professional program, you're practicing this resilience of critical thought, right? Being exposed to these concepts in ways that don't cause the cognitive dissonance that keep you from being an effective learner, let alone educator, right? But really introducing critical thought early and then using it to deconstruct these structural forms of oppression. Really valuable. Super excited about the conversation that will result as students put their thoughts into the chat. I think one of the first ones that I saw is considering the power dynamics. How do students do this? How do students get involved with disrupting, modifying, shifting pedagogy?
I have an answer for that question. Okay. So, okay, so students can shift the oppressive narrative with policy involvement. Okay, I have a million ways, but this is the one that I really want to encourage today. So in fact, at the Johns Hopkins School of Nursing, I was introduced to a book called Health Policy and Politics, A Nurse's Guide. It is a very simple, very easy to read book, and it can truly be helpful to most health professionals. It emphasizes the need to analyze the political context in which policies get on the agenda, how alternatives are formulated, and how policies are put into effect. Okay, so for a policy to be successful, it must have feedback potential, and the audience must be stirred to action based on this contextual dimensions of political influence. It was written in 1987. So the skills and abilities of an interest group in furthering their intended policy, in this case, students, has an influence on legislation. Nurses have demonstrated this with interest groups, supporting appointed positions in the White House, and more nurses working on the Hill, and more nurses obtaining NIH grants. The success of policy involvement by a student is highly dependent upon whether the target population perceives the services provided by the program that the student offers is valuable enough to warrant participation. So this starts with self-reflection on the part of the student. Do you believe in the change you claim you want to see? Nursing students can become significant actors, okay, in policymaking, which impacts the exploitation of non-dominant, non-power holding groups by one, okay, I'm gonna give you another list, okay, researching issues related to a current health policy issue being discussed in your state legislature. 2, research which stage the policy is in, agenda setting, design, implementation, etc. 3, determine what and where the resistance is, okay? 4, research the resistance and propose a counter argument. And finally, 5, you can visit your legislator and present your position regarding the issue. So amidst COVID, email, okay? I really be safe. All right, so gaining this knowledge can support confidence to make change and provides valuable skills to shift oppressive narratives in healthcare. Students can go to congress.gov and type in racism and see what is currently being introduced. Okay. And then to advocate for an issue, you can also join, if you're in nursing, the ANA, the American Nurses Association, that's what that stands for. Use the advocacy toolkit to see if there are relevant interests. Okay. Or through the AACN, the American Associations of the Colleges of Nursing. As a former AACN advocate for the state of Maryland, I use this organization and use a bipartisan Dear Colleague letter, okay, urging the House Appropriations Subcommittee to provide the Title VIII nursing workforce development programs, which supported diversity in the workforce. And then I asked my representative to sign it. So students, you can shift oppressive narratives by getting involved in policy. And this is just one way, there's so many, okay?
And I love that, Emeril. And I also think, you know, I was just thinking about, and I don't know the best way to do this also, but when you're thinking about, you know, doing, and maybe you might have some ideas about this, about, you know, so what about, you know, on maybe like just the institution. So let's say, so for Hopkins, you know, how can you do the same thing in, you know, Hopkins? And one way that I was thinking is that a lot of times you have all these, I guess, opportunities for service, and that is, you know, being on committees, for example. So I guess in response to the fact that, you know, we need to be heard, we need to be seen, we need to be involved in some of these committees so that we can have our voice heard, our opinions, you know, and same for our opinions, and then, you know, and then use that to advocate for what we want and what we need, or then we can contact whoever is our representative on those committees. But I do understand, and I think there was something in the chat about, you know, like given the power dynamics, how can students be empowered to take action when it comes to racism? And I was just thinking about it also, you know, like, so what would, you know, you do with that on the, you know, in the institution, for example. And I don't know the best answer to that, but I guess being seen, being heard is one thing that I can think about. Graham, do you have any thoughts on this? Oh, I think you're muted, Graham.
Yeah, sorry about that. I think one of the things that, you know, students who I encounter, they ask the same question, you know, and the power dynamics are very difficult to negotiate. But I think, yeah, also as in some of the same ways as Emeril said, it's stronger to have a group of voices together rather than a single voice. And so, you know, I also don't think it necessarily, you know, it shouldn't obviously be incumbent upon students to do this work. But you know, quite often it's the students as a faculty and somebody holding that power. It's the students who are in the best position to highlight some of the powers because they're the learners. So, yeah, I think working together as groups to highlight where there are structural problems within your institution, also where you see microaggressions, where you see, you know, where you see syllabi that could be changed productively, and, you know, making sure that your voice is heard at an institutional level as a group. You know, but getting buy-in is really important in that respect. That's where I've seen it be effective at a departmental or a divisional level.
Thank you so much to the panel for those thoughts, thinking about at a practice level. The Nursing Code of Ethics in particular, 9.3 and 9.4, call you into action, into social action around social justice, including in advocacy, but also in representation and in practice. So that Our nurses are not the only ones called by their codes of ethics into action, but I appreciate Emeril highlighting the ways that through your practice you can actually get involved, whether it's APHA or Beyond Flexner for the field of medicine. And then thinking about inside of the institution, there's always power in numbers. Organize for action and change, and Source will help you do that. That's just a small plug. But thinking about how do you engage those who represent you, whether it's student leaders or faculty leaders, and taking in groups, taking whether it's petitions or groups of students to those power levers and engaging them for change. I will be very transparent and say that the role that I sit in inside of the institution, I've seen students do this, and there has been fruit for their labor, though they may not experience it in their time at Hopkins, right? Because the truth is Hopkins relies on your tuition dollars. And so if you show up and say that you're not coming or that you're upset and you're leaving, and I'm not trying to incite anything, but I'm telling you what's brought action is when students have organized themselves and made demands. We actually have gender neutral bathrooms as a result of students 3 years ago organizing themselves and making demands at the School of Public Health. And so there is a definite truth in that call to action. And I dare say, and Graham can attest to this, students organizing themselves to teach themselves. And it is unfortunate that you may feel that it is unfortunate that you would have to do that, but I remind you that the field of academia doesn't require, it's not K through 12, and so faculty are not required to go back for recertification and continued education, right? And so as students who are proximal to the latest publication that you're using when you're completing your assignment, you're actually closer to what's happening in the literature and in the field sometimes than your faculty. And so organizing yourself to teach yourself, not a horrible way to prepare yourself to be the type of future instructor and faculty member that you want to see in the world. Just putting that out there. Okay, we're at 6 o'clock. And that means that we are at the point where we are getting ready to move into work groups. I want to ask, because there have been questions about practice, one last question on behalf of the students present, and ask for each of our panelists to give a really concise, very, very short response so we can then move into work groups in the space where students are practitioners and they're seeing this power dynamic challenge the way that they can advocate for change, whether it's in syllabus in the classroom, but especially as they think about being on the floors and being in the wards. What advice can you give them to hold individuals accountable and hold institutions accountable?
There's several different ways, but one of the ways that I always share, as when I was the former president of the BSNA, I would tell other students, cuss. Okay, and what I mean by that is you tell someone that I am concerned about what I am seeing. It is making me uncomfortable. That's the U. And then the S is safety. So there's a safety issue as a result of what is going on here. As a healthcare provider, those are buzzwords that alert people that there is a problem. So as a student, those are, you can cuss, and hopefully that will help you in uncomfortable situations. Cuss in using the 3 letters I just described. Okay.
Just those 3 letters, no other 3 letters?
No, that's it.
That's such a great response. And I just want to be respectful of time. I think we're going to pivot on that one. I mean, cuss and go. That's what I'm going to invite you all to do, is cuss and go. And speaking of going, I want to give you some tools to navigate the next space, the workshop space that we're moving into. And I want to share a few things with you before you move into that space. Oh, no, I'm premature in that. So what happens next is you break into work groups. You'll be facilitated through some reflective questions by a student leader. And in 45 minutes, we'll rejoin this space for a conversation around what themes arose from your breakout groups, what action plans you all have, and what can you commit to. And then I have a few short commercials when you make your way back. So I'm gonna ask for our administrative support, the rock stars who are co-hosts, to open up the chat rooms, and we'll see you back here in 45 minutes. So much thanks to our panelists. Can we give them an emoticon, a round of applause, a hurrah? Yes, all the rounds, all the way around. Thank you so much to this illustrious panel. I look forward to hearing from you in 45 minutes. Thank you so much, Graham, Emerald. Thank you so much, Ruth-Alma. Appreciate you and the work that you're doing.
Thank you.
Wonderful to meet you both. Wonderful to meet you both. Fantastic.
You as well.
And it's good to see some familiar faces, I guess, in the audience too. So,
Yes.
wonderful.
Okay.
I wasn't put into a workshop, by the way.
Oh, please hold. We're still pushing buttons. Don't mind the person behind the. No worries at all. There are so many of you, and we're so excited to have so many. But it means that we are moving a little slow with the breakout room. So thank you for your patience. To the panelists, you're not responsible for any additional work. You've given of your time and energy. Please go rest. Thank you so much.
Thank you. Thank you so much.
Bye.
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 Bye.